Hello there, Te Luca. I'm going to talk about myofascial techniques for working with the ribs and the rib cage. Lots of applications for this, including back pain, neck pain, shoulder pain, and of course, rib pain, breathing restrictions, etc. You might want to take a minute, if you haven't already, download the optional supplemental materials from advanced-trainings.com/WMC16R, World Massage Conference 16R is in rib. There you can find a free PDF of the slideshow I'm about to give, a ebook, and a mini manual, which is optional but has more detail about the techniques. It has slides, the slides we're going to see. It also has a sample chapter from Advanced Myofascial Techniques Volume 2 that deals particularly with the ribs. It has note organizer pages, which are photos of the techniques we're going to show, and some more techniques that'll help round this out, what I'm going to show you today. There's also some other options there, a free e-letter, and links to our forum, which I'll tell you about in a minute, and some discount offers from our partners, including World Massage Conference and others. You'll get more out of this if you don't try to combine this with other things. It's easy to do, easy to be checking your email, whatever it is, texting people while you're doing this. You'll get more out of both those activities if you do them one at a time. I will invite you to engage your body. Again, this is a medium that doesn't necessarily encourage that or provoke that or catalyze that. We're going to be talking about bodies, and I'll try to remember to invite you to find it in your body, but certainly these are things that you can follow along with a partner and try these techniques. That's how it's largely intended. Or, as we're talking about the different aspects of breathing, for example, or posture, you can check in with your own. Never a bad thing. In fact, why not right now? Just take a second and notice where you're breathing, notice how you're breathing, notice any tension, where you're active, where activation in your body, what might be less active, etc. And then, of course, engaging your mind. Compare this with what you know, and yet once you do that, once you find it that it compares to something you know, the trick is to continue to look for ways that it might apply. Because what can happen is, as soon as you can match this with something you know already, you figured, oh, I got that, and you wait for the next thing. Well, what I'm going to talk about isn't so enormously complex, and I think you're going to see some things here that seem familiar, but look and see if there's not a new dimension to them, or a new aspect that you can bring into what you're doing already, or might send you off in some new directions. And then we do have a forum. This is a recorded event, so I'm not able to speak to you. However, I will be on the World Massage Conference broadcast. I will be in the chat room, but then also in our forum, our private Facebook forum. You're always welcome to come join us there and ask questions or get clarification or discussion about what we're going to do today. The CE questions, if you're doing this for credit, either with us, Advanced Trainings, or through the World Massage Conference. First question, what's the direction of pressure to mobilize the costovertebral junction in the costovertebral joint technique? Number 2, in the piano key assessment, what is the practitioner feeling for? What are we actually feeling for when we do that? Number 3, in the costovertebral joint technique, what is the practitioner's action? What am I actually doing, or are you going to actually be doing when you do that technique? Number 4, why does the instructor, that's me, recommend against using oil for the erector spinae preparation technique? Number 4, which of the following was not listed as an osteoporosis risk factor? A risk factor for osteoporosis. Which of in the quiz, it'll be a list. Which of those is not listed? As I mentioned, the optional ebook has a sample chapter from Advanced Myofascial Techniques, and we're going to be expanding on that chapter in the webinar here. But there also, of course, you can cover more in a book in some ways than in a 90-minute talk. So in the book, if you want to go further, I recommend that either you get this supplemental ebook, or love it if you bought the whole book, of course, and it's discounted on our website. And the address is there on your screen, as well as a code to scan with your phone. We're going to be looking at the chapter about breathing restrictions, specifically the rib chapter, chapter 7. Ribs. One of ribs' function is to define space, to maintain space. for our heart and our lungs and all of the vital structures that pass through the thorax and rib cage. This sense of internal space, this is, by the way, this is an image of the heart suspended between the sternum at the top of the picture and the vertebrae at the bottom. It also, I want to point out the relationship between the ribs and the vertebrae, the transverse process of the vertebrae. The ribs lie inside the transverse process of the vertebrae, and the roundness of the ribs, connected to the sternum in the front and the spine and back, creates this internal space for all those goodies in there. On a quadruped, like this horse, that internal space is horizontal and has, especially in this view from this artist, it has a sense of depth. And it's obvious how that's hanging. The ribs are hanging off of the spine. And that relationship with the ribs to the vertebrae comes perhaps from that orientation, that developmental or evolutionary orientation in gravity. But this sense of internal space, the breath that we can have, or the heart space in some traditions, is a rib cage function. And there seems to be a different sort of mood or a different sort of body-mind effect when we work with the rib cage. It's very different than, say, footwork or hamstring work, which are also great places to get or do hands-on work, hands-on manual therapy with people. And yet there's a different quality that comes in when we work with rib cage, breath, this thoracic space. Just lots of interesting rib pictures strewn throughout this slideshow. Here's one. It's often the rib cage that loses internal space or loses adaptability when we sit for long periods of time, or when we're doing an activity that involves our hands out in front of us, like texting or working at a computer or driving. To position the hands, it often ends up that we lose space in the rib cage, and unless there's support from underneath and expansion and dimension within the body, it's often the rib cage that suffers. And over time, of course, we lose adaptability, and it becomes harder to take other shapes. And this is a more extreme example, of course. Most people would look at this and say, oh, kyphosis. And perhaps it is. You could say that. Certainly this person's spine is very flexed. And it's also a rib cage issue, you could say, or a rib cage pattern, where the ribs have moved close together, they've moved downward in their relationship to the spine, and they've lost the sense of expansiveness and support that would allow different options. Ribs are bones. There are, of course, 12 on each side. They vary from fairly small to fairly large and then get small again. By themselves, the ribs are interesting, but it's really their relationship with the soft tissue that gives them all these things we're talking about. This little simple tensegrity model shows the ribs as struts and the soft tissue, connective tissue, as elastic bands, constructed into a very simple representation of how these kinds of things can work together to create a flexible or adaptable shape that takes up space and yet has structural support and expansiveness to it. The rib cage, we often will think about it as a bony structure. It is, and it's a soft tissue structure. There are many layers of myofascia, there are many ligaments, there are membranes, both inside, within, and around the rib cage that give it its properties, together with the bones, of course. This close-up on the fascia of the sternum shows how richly innervated many of these fascias are, and much of the sensation we get from the rib cage, of course, is based on sensations from nerves. The nerves are carried within the fascial layers. So again, those are both around the outside, deep within, and then in between the different structures of the rib cage. These fascial nerve tracts are the ones that give us sensation, both proprioception of breathing, or lack of proprioception when we're not aware of our bodies, or the downside of sensitivity, which would be pain or discomfort. When the soft tissues and the bones work together, and the awareness that we get of those things working together, when all those things are cooperating, we get a sense of length and dimension and openness and possibility. When they're not working together, we get a sense of we can get a sense of contraction or less movement or pain or less possibility. These two men here are caught in this snapshot at different points in their lives, so there's not quite a fair comparison. But you could say the runner on the left is in a moment where his extensors, where you could say the backside of his body is dominant in terms of its contraction, and so it gives a sense of strain, perhaps, or push, maybe appropriate for the moment that he's in, while the guy on the right, has a length throughout his whole torso, not just the rib cage, but all the way out the legs, all the way up through the top. And that comes from a sense of front and back being in balance, working together. We often think, like I said, of ribs as bones, and we often think of bones from what we know from seeing unliving bones or bones that aren't alive. These are rib fragments from Canada. And this is a rib sculpture, an Italian sculpture made in marble. And this connects to often how we think of bones. We think of them something like stone or something like marble. And yet, if you have ever eaten an unfilleted fish, you've had to deal with very flexible bones, very flexible ribs that don't seem anything like stone or marble. They seem a lot more like a springy, elastic structure than a hard, immobile structure. So ribs in a functional living body are elastic. They change shape with every breath. So we were going to work, of course, the soft tissues being a hands-on approach, and then we're also going to consider the fact that the ribs themselves have quite a bit of flex. Now, the way we conceptualize of that, ribs is flexible, soft tissues is adaptable and sensitive, will change perhaps the way we do the hands-on work. This is one of Robert Schleip's little cartoons showing that the way we conceive of a barrier, say a stone or a rock up on the backside of a door we're trying to open, will influence the way we interact with that door and that barrier. Again, if we think of it as an inanimate barrier, we might open that door in one way, while if it's an animate barrier, like this friendly little ghost here, we might open the door in another. Now, that same is true in the body. If we're thinking that we're moving ribs as inanimate mineral-like bones, we're going to touch them perhaps in one way or think of them in one way, remembering that they're actually vascular, innervated, flexible, biologically active, metabolically active structures that are changing and adapting and sensing all the time. We might work with the ribs really differently. Ribs provide movement. They make the space that we live in, and then they also change the relationship with each other as a part of our normal movements, including breathing. Going back to the snake for a minute, horizontal animals, quadrupeds, snakes, etc., use the ribs for locomotion. Very obviously. Some ribs get stabilized, others get moved. The intercostals are actually locomotion muscles. Not just in the snake, it's obvious in the snake perhaps, but even a quadruped with limbs, there's a stabilization that goes on between the ribs to lever the limb propulsion off of. And then in breath, we need something different. We need an adaptable, expansive structure that allows the breath to move in and out. So we're balancing now in our bipedalism. What we do get stabilization from our rib cage, especially for the shoulders and the neck. And then we also want enough adaptability that our posture doesn't get fixed and we don't lose possibility there, and then our breath can move inside of that. Scoliosis is often thought of as a spinal issue, and it probably is. It's probably a lack of movement in certain directions throughout the spine, but then that also extends, of course, to the rib cage. It's the space between the ribs that changes as the spine changes, and addressing the mobility that we look for in scoliosis involves not just trying to straighten the spine, but helping the ribs be more adaptable and more even in their motions as well. Some of the causes of lost rib mobility would be lost myofascial and kinesthetic adaptability. Both those things. Both myofascial is a shorthand in our lexicon for structural. This is referring to the continuum of fascia, muscle, ligament, all the soft tissues around the bones. And kinesthetic means our sense of movement or stillness. So that involves proprioception, interoception, and haptic sense, the touch sense. All those things together give us our kinesthetic sense. So it's a loss of adaptability in both those areas, and those things can result from habitual postural or movement patterns, stress, inactivity, disease, some of the usual culprits for this kind of problem in the body, unnatural sleep positions, such as you would do on a plane or a car, etc. I am traveling a lot these days, and I get a lot of practice at these unnatural sleep positions. Pregnancy, injuries, strain, or trauma, such as falls, accidents, coughing. People can break a rib with coughing or strain the ligaments around a rib through coughing. Surgeries that go through the rib cage or between ribs, those kind of things can cause a loss of mobility once the surgery has healed. Our approach will be our sequence that I'm going to show you in this little mini sequence I'm going to demonstrate through the videos will involve layer by layer, essentially unwrapping the rib cage. This body painting from the Japanese artist Chusan is done with acrylic on this young man's body, and it shows how underneath his skin and outer layers of soft tissue, there is a skeletal structure of the rib cage. And this animation that Jeff Lynn put together from the Visible Human Dataset shows how the wrappings of the body form a three-dimensional spider web, in Ida Ralph's words, three-dimensional matrix that are related to our shape, but also influence our movement and our function. The lighter layers in this animation being the superficial fascias, which are enormously sensitive. The darker ones being the deeper intermuscular septa and deep fascias and pleural fascias, etc., that are even denser and influence our movement in their strong structural qualities. The cross section here will show, if I can get my mouse there, the rib cage. Here's the vertebrae. And the rib cage is actually relatively small in a cross section of the torso. This is sternum here, so these would be ribs with intercostals, surrounded by this relatively small rib cage, surrounded by lots of erectors, paraspinal muscles, shoulder musculature, adipose tissue, which is embedded in superficial fascia. And then the shoulder girdle, which we'll go into in a second. Here's a close-up on that shot. That's one of Lisa Nilsson's amazing cross-section reconstructions that she does out of rolled paper. So this is entirely reconstructed out of rolled paper, which is a lot like the fascial wrappings that go around all the different compartments here. But I mentioned the shoulder girdle being around the rib cage. This dissection that was done by Bassett in the 1950s shows that those kind of proportions in an interesting way too. How especially the upper part of the rib cage is relatively small, and yet the shoulder girdle is massive. There's quite a bit of structure and muscle, even the bony components of the shoulder girdle around those upper ribs, so that really to approach getting a full breath and making sure the rib cage is adaptable enough to allow the spine full movement would probably involve making sure the shoulder girdle has a similar kind of adaptability. So the precursor to this rib workshop, a rib webinar would be a shoulder girdle session or some shoulder girdle work to make sure the shoulder girdle is adaptable, free, and spacious. But then once we get down and ready to work with the ribs themselves, here's the little mini sequence I'm going to show you today. We're going to go through 7 techniques. They can be used a la carte, meaning one at a time, mixed in with your existing work. You'll see ways to do that as you watch them. Or you can use this as a template for the sequence of probably at least a 45-minute session, probably more like an hour, maybe 75-minute session. Mixing them in with things to help the rest of the body feel complete, if that's the model you use, or using them as a series of sessions if you're doing shorter visits with people. The costovertebral juncture is where we're going to start. Those are the joints between the ribs and the vertebrae. They have a lot of ligaments that join them. Each rib touches a vertebrae in 3 places, one at the transverse process, and then a vertebrae above and a vertebrae below at its head. And each of these places it touches has a synovial sac, a synovial sheath that allows for quite a bit of movement, wrapped by a ligamentous structure that includes membranes for joint capsules, but also restraining ligaments to allow this structural stability here. And then in this region too are where the spinal nerves exit and the sympathetic ganglia are, and the dorsal rami of the spinal nerves, and lots of really key neurological structures, as well as the intercostal nerves themselves, which run out between the ribs and loop around both between the ribs and also on the surface, the cutaneous branches that are often involved, or probably the signal carriers when we get a nociceptive signal that we interpret as rib pain. So these little junctures right back here where the ribs join the spine are very close to a lot of key neurological structures, as well as being key structural components. Like I said, there's a lot of ligament around those junctures. That soft tissue arrangement, which is pretty dense and multidirectional, influences quite a bit of spinal movement and certainly breath and rib movement. Now, all of that is deep to these structures, which here is the thoracolumbar fascia surrounding the erector group. So if we take a look at what we get when we go to the butcher and get some ribs, what we have is largely erector spinae or paraspinal muscles with some of the larger back muscles, say latissimus, wrapped in thoracolumbar fascia. And in this view here, the butcher has cut away the costovertebral joints and the vertebrae, which would be here where the rosemary is. Another view of that same anatomy. Here are costovertebral junctures. They are deep to or anterior to the spinal erectors, the spinal erector group. So to really get down to affect them directly means using the ribs perhaps as a handle to get in there, and we're going to do this, is to work the erectors enough that they're elastic to an extent that allows us to get to the costovertebral junctures more directly with our pressure. It's worthwhile remembering that erectors aren't just something that's over the rib joints, that many, I wonder if all are. I'd have to go check. No, I don't think all are, but most of them are rib muscles. Most of the erectors, let's say, are rib muscles. I'm sure to get some mail on that if I've misspoken, but certainly longissimus, ilicostalis, and probably, I would guess, mustus spinalis are all rib structures, and they do their job of stabilizing, holding us up, allowing us to bend, etc., by their attachments to the ribs. So our first technique, the erector spinae preparation technique, its purpose, preparation for deeper work with the rib to spine juncture. We're doing it by, you'll see me in the demo here, I'm about to play a video of that. I'm using slow friction. I'm feeling for layer to layer differentiation and glide. I'm typically starting with the skin and just the superficial fascia before I try to get down into in between the erectors themselves. And I'm not using oil because I want to be able to feel for those layers. If I have a lubricant on the surface, I'm going to slide in a way that feels great and does a lot of relaxation and has plenty of therapeutic benefit, but it doesn't allow my touch to feel and move one layer upon another in a way that allows for greater tissue differentiation in a layer sense. Once that's done, again, this video is going to show you the costovertebral joint technique, where I think in the video I use my forearm perhaps going the other direction. I think I was working in a cephalad or upward direction in the video. And then I do also show, I believe, the thumb version where you can get very detailed. Once the tissue has been, the elastic quality of the tissue has been established from your work, you can get very specific about the spaces between the ribs, right up where they meet the spine, which is interestingly where the spinal nerve exits are. So enjoy this 5 minutes of me demonstrating these techniques. Feel free to take notes in your note organizer, etc. If at any point you need a replay, the World Massage Conference was kindly offering a 24-hour replay for the preview, and then I think you have quite a long period of access once you sign up for the actual conference itself. So, and then, by the way, this is a preview. These are kind of rough cut. You'll hear sound issues, things like that. These are rough cut previews of a class that was just taught about a week and a half ago in Portland, Oregon. Thanks to the class there for allowing their demos to be filmed and everyone worked together and got that done. So enjoy this preview of an upcoming DVD as well. Technique A03, the erector spinae preparation, especially as we start to work with the costovertebral joints, we need to work with the soft tissue that's over them. So this is just good old myofascial work using my forearm and not so much the point of my elbow. And I have a big footprint. I'm using the arm to stabilize that forearm. And I use that tool to feel at first the outer layers, say the thoracolumbar fascia or even the superficial layers over that. How's that pressure? Okay. Great. Okay. And you can breathe a little more too. You can like really move the ribs with your breath as I anchor those layers in a caudal direction. Super basic, super effective, but there's a reason why my friend and mentor, Robert Schleipp, calls this technique best friends forever. Because we all need this, and this is welcome.
And you recommend this without a lubricant?
Without a lubricant, I can feel the layers in a way that I can't so much with a lubricant. The lubricant would allow me to flow through it and move fluid, say, and be soothing. But I don't get the places one layer doesn't slide over another, which is what I'm up to.
So as an example of feeling with layers, could you verbalize what you feel?
Yeah. So we started with superficial skin and superficial fascia that slides on, say, the thoracolumbar fascia that's around the erector itself. The wrapping of the erector itself would be that thoracolumbar fascia. So I'm feeling for that interface early on. Can the skin and the layer just under the skin slide on the muscle underneath it? And then once I get that kind of movement there, starts to release, then I can go down, say, between bundles of the erectors themselves and start to feel, is there adaptability, is there tissue elasticity right in between the bundles of the erectors? Does that help? Yeah. And then her breath is one possible movement. I could also start to engage arms, so you could reach up above your head real gently, so which brings in all the structures of the shoulder girdle. Yeah, you can do both sides or just this side too is fine. So I'm just an anchor that she's moving around. I'm a friendly stone in the stream that she's flowing all around. And I can extend this technique, that's great, to different layers and different depths, then I can extend it all the way down to the sacrum, say. Ribs don't go down there, of course, but the structures do. Any questions?
I think it's awesome that you have her hips propped up for this move, because if she had any kind of lumbar constriction or low back pain, it would exacerbate it without that.
She's on the body cushion right now, which keeps her lumbars long, but that's something to be aware of if she wasn't, for sure.
So,
matter, like working down?
Is working down, working up matter? 100 years from now, who's going to know? No. So in that sense, no. In the other sense, you'll feel different things. And so I don't think there's a correct direction. It's more strategic. And especially as I get the outer layers warmed up, which I tend to work like that, is I want to get more specific in the next technique, which I'm just going to go right into. In that case, I'm now working, let's say, upwards, because that allows me to get into the space between each rib where it meets the spine. And I'm using my forearm here, that now that we've prepared the outer layers, to essentially just provide some pressure into that space between the ribs. And we'll bring out the skeleton and actually show where I am too with that one.
Till, could you comment on your direction of your pressure? Are you going medial, lateral?
Yep.
Is it straight down?
For the costovertebral technique, I'm just holding into that space, but I had to find an angle that took me into that bony space. And Karen's working great with her breath in a great way, so she's opening around these places. Essentially, I am feeling into those spaces between the ribs. Yeah? And then she's moving and breathing to open up these joints here.
So it's kind of a medial pressure toward...
Yeah, I found that I had to actually go in that direction to feel the shapes of that area, and let her breathe in each of these places. And I think the book shows a variation where I'm using thumbs. Yeah? That was good in my 30s and 40s. But I minimize it, anymore. The less I can use my thumbs, the better I am. And I still save them for a couple things. But you can do this with a forearm or another tool pretty easily. Or like a supported thumb, someone's saying, yep. Or a knuckle, some people, or my favorite, just a sensitive, sensing, gentle, careful forearm. Some variations on that technique, on the erector spinae techniques, include the one we just saw, which was the erector spinae preparation. But then there's also some more specific work in the laminar groove. That is in your mini manual. It's part of our spine workshop rather than our rib workshop. And the laminar groove has the smallest of the paraspinal muscles, the muscles right around the spine. These are rotatories and multifidi in this image, and it has the levator costarum and the other small structures that attach to the ribs. It's a great, detailed, focused kind of work to do right there in the laminar groove right next to the spine. Same tools that we showed, slightly different focus. And then the iliocostalis, this larger, more lateral structure, is also a key rib structure. And that can be worked by just feeling its thoracolumbar fascia covering, or especially by feeling its tendinous insertions on the rib, on the lateral rib cage. And you can find those by just starting laterally and moving toward the spine until you run up against this speed bump of erector tendon. And by leaning on those, and especially by encouraging breath, is a very effective way to work with that iliocostalis group. Another picture of that from Primal Pictures here, the iliocostalis in orange. So now that we've prepared the erectors and the costovertebral joints, at least as a first pass, we're going to do some assessment of their mobility using this technique, the piano test. And you can be done either supine or prone. I believe the video shows it supine, but you can imagine how it would look prone. It's essentially moving each rib in turn as you would the key of a piano and feeling for the mobility there, the anterior mobility in this case. So if my hands are underneath the rib cage, you're going to see me in the demo. I'm lifting that rib anteriorly, feeling for a gapping or a mobility potential here at that joint. I write down at these costovertebral joints again. And then based on what we find in that mobility testing, I believe we go right into the spine ribcage differentiation technique, where we are encouraging the rib to be mobile in the direction that it wasn't. So if the piano key wouldn't play there, then I'm sliding it forward or pressing it anteriorly. in a way to help mobilize that joint and release the soft tissue that might be inhibiting that motion. Technique A6, the rib mobility testing or the piano test. I'm going to reach under Karen and then lift each rib in turn, something like a piano key, and feel for the rib's ability to move anteriorly. I'm going to feel that some move anterior easily, others not so easily. That's going to let me know about the mobility at that costovertebral joint. It's both an assessment and a mobilization, of course. So it's something like this. Where I'm just lifting anteriorly on each rib in turn. And part of it is objective, meaning I want to feel how it moves, but a lot of it is subjective. I want to know how she feels its movement too. So far, yeah, we kind of have like an F sharp down here. Yeah? Is that the one that you were feeling too, or the zone? Yeah. But otherwise, as I move up the spine, pretty mobile, except for a couple of ribs right here at that level. So that's, again, the assessment. Now the technique, I could just lift there with my hands, keeping them comfortable, not straining anything, but from underneath, I could just simply lift that rib. So I'm feeling the bone. This isn't feeling for knots in the rectors. It's feeling the movement of the bone. And yeah, she's already gone into some gentle breath.
So you'll go all the way to the floating ribs?
You can gently check the floating ribs too, but it's gentle. It's not, I wouldn't be doing, now I'm doing a release. I'm doing more pressure. I wouldn't be doing that necessarily in that zone. Okay, so we've identified an area. Now I'm going to show you a couple ideas for working with that. Why don't you turn on your side facing that way. So, and you want to be, a tight little ball. And our zone, and we can see a little bit of dermographia there where I was pressing. Our zone was right here. And those are the ribs that I'm looking to move anteriorly. So with a very gentle forearm in the direction that parallels the joint space. Doing okay? So I'm sliding the rib anteromedially on the vertebrae. Forward and toward the midline.
So your pressure is towards the midline?
Mm-hmm. Forward and towards the midline.
Towards the midline.
Yep. This is actually an active technique where I lean on the rib. Pressure okay, Karen?
Yeah, it's good.
And then you find this place in your spine with your breath. So she's actively having to support herself a little bit. Not enough that she's really, hopefully, tightening up or working hard, but there is an integration of support that has to go down and up from here, as opposed to finding a position that's very relaxed for her. So yeah, as you exhale, like you can send this vertebrae backwards toward me. And then, that's great. We put her in this position. Why? Do you remember some of the reasons why she's in a flex position? It opens the space for the ribs. Having her curled like this provides some natural support for me to push against. Rather than face down, where I'd be pushing against the table, she gets to find a way to move backwards toward me. That's the active part. All right. Moving the ribs forward where they didn't go forward before. Forward and medial. And most people I'll do a couple places. She just had this one region there.
What if you can't feel the ribs?
If you can't feel the ribs, get some help. Here in the live class, you got that advantage. Get one of us over to come help you find the ribs. If you're watching the recording or we're doing this later, it might mean you need more preparation. There might be so much erector tension in the way that it's hard to palpate them. And so you might spend more time with preparation.
I'm thinking of someone who had a lot of trauma and they have very thick skin. And it's hard to separate the skin.
Or sometimes people are massively muscled here too. There's some advantage to just pretending
Yeah.
that you can feel the bone. So you just put, you're going to be feeling muscle, say, but then just pretend or imagine or work as if you're going down to the bone, and usually there's some benefit in that too. So a little review. In the piano key assessment, what was I feeling for? Would you say it's, and you pick your answer, tight myofascia or knots, because there's usually plenty of those in the erectors, passive bony mobility, rib alignment, were the ribs all lined up or were there prominences, that kind of thing, or evenness of the intercostal spaces? Was I feeling for that space right next to the costovertebral joint and making sure they're even? What would you say is the primary thing I was feeling for? Well, it wasn't rib alignment. Rib alignment is really influenced quite a bit by shape. There are times that you can actually dislocate a rib, and certainly chiropractors have a model where they describe a rib as being out, or they have a positional model where that's what they tend to work with. That may be the case, but in this model we're thinking more mobility, and that seems to help us be very effective and be very focused in the work we're doing. So we're thinking less about where a rib might be, quote, out, if it is, and certainly what the chiropractor will often describe as a rib out, I will feel as a mobility change, a mobility restriction in a particular direction. Often it'll move, in this case, more easily posterior than it does anteriorly. So the piano test didn't check for tight myofascia. It wasn't just feeling for where the erectors were tight. It also wasn't feeling for evenness of the intercostal spaces. It was checking to see, did the bones, the ribs, in other words, move? Did they move in this anterior direction? Now, there's other directions of rib motion too. There's rotation, there's gliding, there's bucket handle motion, there's pump handle motion, etc. This can get very technical. All these motions are happening at once. Here's a detailed study of rib motion in iguana. In an iguana, actually 5 iguanas, to see how these motions were coupled and how the magnitude and what the intercostal space did and what happened right at that costovertebral joint, our featured joint so far, in breathing. And we're going to simplify it because, like I said, it can get very complex. We're going to focus just on the bucket handle motion. And you can imagine or conceptualize this as the ribs' relationship with the spine, moving in breath like the handle of a bucket, and also the ribs' relationship with the sternum, having some of that pivoting motion too. So here's a 3D computer modeling of one of the iguanas that was studied in this research project around rib motion, the costovertebral joints. And it was interesting what they had the iguanas do was run on a treadmill. They had to move on a treadmill for a while to get them breathing harder and bigger so that the rib motion would be exaggerated. And this shows in a 3D sense what the ribs were doing with breathing. And there's quite a bit of motion at the costovertebral joints that we were just working at, and motion too at the sternum. This whole thing moving like the handle of a bucket. Now, when they don't move, or when they don't move evenly, you get, let me put it the other way. When the spaces between them can't open and close evenly, you get a restriction in the rib motion. And that can be from the costovertebral junctions that we've worked through seen through the thoracolumbar fascia and all the erectors. Or it could be from an inadaptable intercostal space. The intercostal muscles not relaxing, or the fascia not having enough elasticity to it to allow that movement there. And the metaphor there would be like an accordion whose pleats didn't open. We want the whole thing playing. We want everything opening and closing in our breath to the extent that's practical, of course. And we have a technique from our spine workshop. This video here that I'm about to show was taken quite a while ago. I would guess probably more than 10 years ago. Still hopefully useful. And it has been pointed out to me many times over the years that intercostal is spelled wrong in the video, so my apologies for that. But go ahead and have a look at one way to work with these bucket handle motion of the intercostals. B5 bucket handles. Now, ribs are like horseshoes attached in the back, in the front, or a bucket handle. Sorry, am I tickling you?
No.
Okay. And I'm going to get a hold of a rib, follow it up on the inhale, and then hold it there while she exhales out from under me in order to stretch the ribs out from underneath. And then I'll do the opposite. I think the picture shows working toward the head. Is that right? Downward? Okay. So I'm doing the opposite. Shows both? Yeah, you're right. Okay. So I'm doing the bottom picture first, right now.
So are you right on the rib or under the rib?
I'm right under the rib,
Right under the rib.
pushing up on it. Maybe we'll try a low one for you. How are we doing, Karen?
Excellent. That's good.
So she inhaled, lifted the bucket handle, and I'm continuing to hold it up as she exhales out from under this. Now she's been hearing me talk, and we practiced this some before too, but your clients will need a lot of coaching on this. And I'll say, let your exhale drop right out from under this, or exhale from here down. Those are some things to say to help people really find a way to release the rib cage below this point.
You're maintaining constant pressure through the breath.
I actually take up the slack as she gives it to me. Every time she inhales, I get a little more and hold it higher and higher each time as she drops out from under. So now I'm focusing on some of the lower ribs where her...
So you're going for one rib at a time rather than a whole,
Yeah.
rather than the fascia above and stretching.
Yep, I'm going for one rib at a time. And it's helpful to remember too that the back attachment of the rib is higher than the front attachment of that same rib. Now, the other way, if you have time, you can go through all the ribs this way. It's marvelous. If it's part of a larger session, you pick the 2 or 3 most stuck spots and work them. But the other way here, I'm going to, same thing, get a rib. Let's try one of your lower ones. Here's a rib, and you take a breath in, and then as you exhale, I follow it down, and I barrier, I hold it down, and you inhale from here up. So essentially lift the upper ribs off of this.
Could you repeat that?
Yep. So I follow the rib down on the exhale, and then the instructions were for her to breathe from here up. Inhale from here up to lift the ribs off of this one that I'm holding down. And what you'll find is that one direction seems to give a lot of these for people, one or the other, kind of depending on their pattern.
This is a little more.
This is the one for you? A little more what?
More release.
More release, yeah, I feel that too.
Will they sometimes both release up and down?
Yeah, you'll have people that you can get release in both directions, but people will tend to get more of a release in one direction than the other. What's this like down here, Karen?
That's it.
That's it, huh? Okay.
Yeah, that released a lot.
Did it?
The spine and low back workshop was really transformational because I have a lot of low back issues, and I felt better after doing that workshop than I had in years.
So the bucket handle technique works in 2 directions. It's a little review here. And these page numbers here refer to the rib manual, the rib workshop. Similar techniques have different page numbers in the spine workshop. But here I am anchoring a rib downward toward her feet while she inhales from that point up. And then I turn it around the other way if need be, where I anchor the rib in a headward or cephalad direction while she exhales from that point down. And that allows her to feel into individual intercostal spaces, both so she's finding a way to get movement in there, both through directed proprioception and through actual movement into these various spaces, so that we can have this fullness of possibility and a lot of range there. This is a technique that you can take quite a bit of time with to really get all of these things moving. Or you can pick on one or two spaces that aren't moving much and get them to, again, adapt and change. But I want to emphasize our focus is on movement rather than on just two ribs that feel like they're, well, let's not say that. It's not a static assessment. I don't feel the ribs and feel two stuck together and then pry them apart. I ask someone to breathe and feel where they open and where they close. Where they don't open and breathe is where I focus the technique. Something interesting about this rib cage, I don't know if you've spotted it yet. Most people can look at this and tell it's not quite normal, but let me point you toward the costal arch, how narrow the costal arch is, and as a result, how narrow the lower part of the rib cage is. This is the rib cage of a corset wearer, of a woman who wore a corset regularly enough to change the shape of her rib cage. And corsets are back in style, I'm told, but this look, the look that we're going for, a very narrow waist, of course, had effects on the shape of the bones, but also had to move the organs out of the way. Here's a diagram showing how the liver had to drop and the intestines had to drop below their otherwise normal positions in order to allow that narrowing of the lower ribs and immobility. And what we're going to do is, you could say, an anti-corset approach. We're actually looking for more possibility of widening and adaptability at the ribs. So why don't you watch this and check in with your own breathing. This is a little animation showing how the ribs and diaphragm move. Perhaps, in a body there's actually even more movement throughout the entire body, but this does show how the ribs do their pump handle motion of raising in the front. Almost looks like the diaphragm's rearing its head towards us like a cobra. Well, that's the pump handle motion of the ribs with the sternum lifting slightly on the inhale. It shows the bucket handle motion, how there's some pivoting and raising there, raising and lowering with the breath. And it shows the caliper motion, how they open up and get wider towards us with the inhale. Right at the costal arch, that's where we're going to actually work with this. We're going to use this rim of the costal arch in a very delicate way, keeping in mind that most people have ends of floating ribs there. This is a place where a fall or an injury or a coughing injury can sometimes damage the cartilage or the ligaments that hold these free ribs. And so it can be very sensitive, and we're not trying to further mobilize something that's been injured in that way, but we're using a broad touch on the entire costal arch, being mindful that right under this is the liver. And the liver is a very soft structure that could be, in theory, damaged by some aggressively poking under the rib cage. So we're actually not going to poke or move inside the rib cage. This whole technique is done on the rim of the bone without going inside the rib cage. Technique B5, the costal arch release, moves into a new subset of techniques. The previous three techniques dealt with movement in the horizontal plane, caliper motion of the ribs. This one continues that theme, but takes it more specifically now into the diaphragm, and these next techniques are going to work through that whole visceral midsection of the rib cage. So I'm not digging under the rib cage, costal arch with this one. I'm on the rim of the costal arch. That's a really important distinction. There are ways to dig up underneath the costal arch to try to touch the diaphragm directly. Just to keep the liver safe, we're not going to do that. We're going to show you another way to really work effectively with the diaphragm, and that is using the rim of the costal arch. I'm going to follow it wide when Stephanie inhales. So her inhale allows me to take it wide, and then I stabilize that against the exhale. So effectively widening the diaphragm. And this part of our goal here is increasing proprioception. This is a place that loses a lot of body awareness just from sitting and collapsing and folding right here. So by just giving her body the experience of room and space, it's waking up a new possibility, remapping her body from the inside out. And then I would repeat it on the opposite side to open the entire midsection in both directions. Any question? You're making some comments. Anything from your side?
Just it really feels different.
Feels, yeah. We should do both sides, huh?
I've got a partner.
You got a partner? Okay. Any other questions? Very good. So sorry about the sound on that. It's a draft copy. Like as I said, it was a little preview for us. That sound issues, hopefully we'll get those worked out in the final version. The technique we just saw is called the diaphragm technique, or diaphragm/Kostler technique in the Advanced Myofascial Techniques book. And there it's described in greater detail. The anterior-posterior rib release technique is a great way to wrap up this little sequence we've done. It is it can be done in two ways. It can be done with a firm touch, or it can be done with a very light touch. It lifts the ribs from underneath, like the piano assessment. So we're thinking, again, that costovertebral juncture to actually decompress that with some lifting from underneath. And it also compresses gently on the same rib in front. So it's moving the same rib posteriorly against the sternum, thinking about all of the little synovial joints that exist between the costal cartilage and the sternum itself, the costal cartilage that exists even between individual parts of the costal arch, and about all the ligamentous and fascial connections here that exist between the costal cartilage and the sternum. Lots of perception here. In fact, that earlier picture we had of the fascia with the ribs in it, that was sternal fascia. So a very sensitive area, as you know, if you just touch your own sternum in these costal-chondral junctures and at the sternocostal junctures, very sensitive areas. Technique 8, the AP rib release. We did an assessment with the piano. We did an efferent technique where we're working with the spine ribcage differentiation. Now I'm coming back to afferent, to it's more of a sensing technique to both integrate the morning's session and to make sure that any remaining restrictions to that anterior-posterior mobility are being addressed. So here, with one hand under the back of the rib, like we did with the piano assessment, one hand on the front of that rib, I'm going to gently approximate those ends, bring them together. It's not a big compression, it's just a gentle sensing touch that puts an impulse towards that direction and listens to how our body responds. Something like that. Now, as we saw in the anatomy, by lifting the posterior part of the rib forward, it actually mobilizes that joint space and the costovertebral joint. And the same thing happens in the front with the costochondral joints. That little bit of that posterior pressure on the rib actually helps that joint be more adaptable and mobile. So once I do that, then I wait. And this is the afferent part. It's her breath and her movement that come into that and actually help that rib ease and be more mobile. It's a bit like the rib begins to float, or it just gets a little bit more, there's a little more of a drift there than a resistance. And at this point in the game, I'm not trying to push really hard to get it to release as much as hold it really clearly and allow her movement to do the motion. And she's doing it on her own because she's hearing me talking, but in my practice, I might actually invite someone's breath there, like just let your breath move between my hands here. Yeah. That was really clear. Is there even more that's possible in the back? Okay, let's see. Because what I felt was, movement in the front really clearly, and maybe a little less in the back. Yeah, that's different. Quick study. But meanwhile, by approximating those rib ends, I've helped the rib be mobile enough that her breath can move it.
And so how would you get to the first rib? What would you do there?
First rib's pretty hard because of the clavicle and everything. We have different techniques for that. But you can work the upper ribs certainly as a group, certainly the second rib and down with this technique. So I want to just re-emphasize the work in the front and the ribs attaching to the sternum. There are lots of muscles there as well as the soft tissues, both inside the rib cage and outside. And these muscles are both movers and proprioceptors. They allow us to feel what's happening there and affect the movement that's happening in the rib cage. So a little review of our mini sequence we've just been through. We started by preparing the erectors so we could get down to the costovertebral joints. Then we tested and compared the whole set of costovertebral joints, both sides of the spine, with the piano test. Based on what we found there, we turned people on their side and did the spine ribcage differentiation technique to very specifically focus the work into individual joints that weren't as mobile. We began to put things back together with the intercostal technique, otherwise known as the bucket handle technique. So getting the whole rib cage to open and close like the accordion. We did the costal arch release to make sure that there was some dimension possible in the midsection there where the diaphragm is. That's a place that on many of us loses dimension, loses space when we're sitting for long periods of time. So just waking that part of the body up can shift someone's awareness when they're sitting. In fact, it's a great chance to feel that now. As we're doing this, I'm shifting in my chair here, just feeling into my own costal arch and midsection. And then we finished with that anterior-posterior rib release, just as a way to back out of the system and go to the afferent touch, the listening, perceptive touch that evokes more sensation on the client's part as well. Now, some things, as in summary here, some things to keep in mind when we're working with ribs are that sometimes rib pain or discomfort could be from acute injuries, bruises, strains, or fractures. And these techniques I've been showing you can be adapted for that kind of thing with a very light touch, a very indirect approach, say. But the way we've been showing them here, we were assuming that you're not dealing with an acute injury, you're dealing with something that's a movement restriction that's been ongoing. And so if there is a bruise or an acute strain, then you would find other ways to work with them. Costochondritis, which is an inflammation of the sternal cartilage, a painful inflammation of the sternal cartilage, so right next to the sternum, it can get very painful with breath. Actually working with the costovertebral junctions in the back it just anecdotally in my own practice seems to help relieve some of the discomfort people have in the front from costochondritis. The conventional view is costochondritis typically resolves itself. It's not generally known why it occurs. Sometimes it does seem to be a use-related or perhaps another infectious condition can lead to it, a phenomenon related to those things, but it seems to resolve itself generally in 3 months, I think is the conventional wisdom. But I've gotten more comfort for people by working those costovertebral joints, but we're not going to work right on the inflamed sternal cartilage in most cases. At least that's the general approach for inflammation. Don't work right on it. And that goes for pleurisy too, which is can be very painful or moderately painful, can be experienced as rib pain or rib cage pain or chest pain or back pain from inflamed pleura, the lining of the lung cavity. And then inflammation can be from an infection or from an irritation. And that's something to keep in mind and refer to medical attention if someone's rib, chest, or back pain isn't responding to your hands-on work. And then along those lines, cardiac issues can also be experienced as chest pain or rib pain because those internal organs aren't very good at locating sensation. Often sensation that or nociception or signals that are being generated in the organs can be experienced or located by our brain and other parts of the body. So in a hospital or in a doctor's office, typically, if you have unexplained chest pain, that's cause to go right to the emergency room. Do not pass go. So keep that in mind too. And then hypermobility. We mentioned that can be from trauma or strain or an injury. CPR will often leave people with trauma to the ligaments or to the bones themselves or to the cartilage. And after that's healed, these techniques can be useful, or elsewhere in the rib cage, away from the traumatic injury. Osteoporosis, osteopenia, which I'm going to speak about a bit in a moment. But first I want to show you, typically a fractured rib, say, is just allowed to heal on its own. If it's several fractured ribs, or they're completely fractured in a way that the rough ends of the ribs could be damaging the soft tissues around them, especially the pleura or the lung tissue underneath, then there will be different medical interventions that are made. Here's one example, say a plate that's screwed, one type of plate that's screwed to the ribs. The installation of the plate is itself fairly traumatic. You can see in this image of the surgery to put those plates in that there's quite a bit of tissue disruption. It's difficult to go between the layers or arthroscopic in some of the more sophisticated surgeries. This is a traumatic repair where you just need to open up the fascia around the rib cage apparently and sew the plate to the rib. Probably the lesser of two evils if you're in danger of having a punctured lung or already have one, but it can cause that disruption to the muscles, the myofascia, the superficial fascia, the deep fascia around the rib cage that our work can help someone recover from after the healing has had a chance to go through a cycle. Many times you'll feel bumps on ribs. That can be from a unionized fracture, a fracture that has repaired itself. Or you can feel variations in rib shape. That's one reason not to just assume that because ribs are close together, they need to be apart. Sometimes the ribs are conjoined. And here, this is showing a fifth rib that's conjoined. So don't assume that just from the shape that it's something that you need to mobilize. Actually feel what happens when you breathe. When your client breathes, what happens to that space. And we're looking for an evenness functionally, not just structurally. So here's, we're talking about osteoporosis now. Here's the normal bone architecture in a third lumbar vertebrae of a 30-year-old woman. Thanks to Alan Boyd for these images. It's showing the trabecula within the lumbar vertebrae, comparing this image to the trabecula of an 89-year-old woman with osteoporosis, osteoporotic bone. So much less dense, much less bone, a much more spacious lattice work. And another view of that, even more spacious regions where bone removal is happening faster than bone deposition in osteoporosis. Everyone has bone removal, everyone has bone deposition, and then the bone removal just accelerates faster than the bone deposition and leading to a net loss of bone over time. Something to be aware of is in any kind of body work, but especially when we're working, say, with rib cages, ribs, because ribs are thin bones and they move quite a bit. So it's good to know that it affects about 3% of people in the U.S. It affects both men and women. It's hard to detect without being screened. Sometimes the first time someone knows about it is when they accidentally break a bone. So it's a great idea to be on the lookout for these screening signs, and screening is recommended when you see 3 or more of these 5 things. Someone is over age 65, Caucasian or Asian, female, low body weight, family history of osteoporosis, and then there are some other risk factors there, but really the 5 that are conventionally used for screening criteria would be if I'm a skinny white guy, but I'm under 65, that means I have 1, 2 of the criteria, but not necessarily 3. If I'm a skinny old white guy, and I'm not the skinny guy, but I'm I'm not as young as I used to be, and I am Caucasian, I have 2 of those criteria still. Actually, if I was skinny, I would have 3, and that would probably be a good idea to have me screened before doing direct work on the rib cage. Now, these other risk factors there are also things that have been correlated with bone loss, as well as birth control, hormonal-based birth control, etc. But it's useful to remember that bones aren't just mineral, that bones, when we think of them as mineral, again, we think about their fragility. Here's some calcium carbonate, which is chalk, showing how fragile it is. Bones, the mineral in bones is calcium phosphate, so it's a little different. And it has that kind of flexibility that we talked about with the fish bones, where in a living body, bones can be enormously flexible. We are, taking advantage of that when we do our work and feeling the mobility. And it could be that by bringing people's awareness to that mobility and having them move more, the body allows more of that mobility. Bones, what gives bones their flexibility is the connective tissue lattice. These are collagen fibers within bone. The collagen fibers have little apatite calcium phosphate crystals embedded or bonded to their surfaces. And the collagen forms the lattice for these crystals to form. So it's not like the chalk where it's just all calcium crystals packed in together. It's actually like a carbon fiber structure where there's a fibrous matrix of very, very elastic and flexible fibers embedded surrounded by these calcium crystals. So bone is about half mineral and about half organic compounds, and the organic compound is mostly collagen. So here's a specimen that's been treated with hydrochloric acid to dissolve away the mineral on one side and bleach to dissolve away the collagen on the other, showing how it's about half and half in terms of the fiber and the mineral component of bone. And then a lot of that too is water. So on drying, the collagen part shrinks. Dried bones are about a third smaller than living bones, they say. So living bones are more like starfish, you could say. Starfish, when they're dried out, they're brittle and hard. When they're living, they're actually adaptable in slow motion. They're not as adaptable, say, as a jellyfish, which doesn't have bones. But the starfish is adaptable. With a gentle touch, you can actually encourage a starfish to change its shape in a way that they don't seem to mind. And the same way with ribs. We're going to gently move. When we move the ribs, we got to keep in mind that they are slower to respond, that a gentle touch, that we've ruled out our contraindications, and that we're using the bones and the ribs like a sensing approach. We're using the bones as ways into the sensory system, not just a mechanical structure we're using, but a hands-on effect that works with the whole structure that gives our body its space, our thorax its space, the heart and lungs, and is beautiful. It's beautiful, and it has a certain kind of beauty, just in its regularity and its spaciousness and its mobility. Now, some of the references for what I've been talking about are in the Advanced Myofascial book, Volume 2, at the end of the ribs chapter. For sure, I recommend going to check out our other resources, which include our Spine, Ribs, and Low Back DVD. These are on sale on our website. They're also available on Amazon, but you get a better deal, believe it or not, on our website. So have a look at that URL there, a-t.tv/spine video. That'll take you right to the spine video page, or scan that code there. And then our myofascial books go through these techniques in detail. They were a lot of fun to write, and they're out there for your further learning and development. We're going to be doing a group where we go through each of the chapters, an ongoing group. And so watch for that as well. A big thanks to Primal Pictures. They've been supporting us for years by allowing us to use their amazing software that's actually based on a living body. So it's not just an artist's conceptualization. It's actually based on someone's actual body. And then the specials again. Let me just remind you, you can download the slides that you've seen as a free PDF, or you can go get the optional ebook that has expanded versions of those slides, as well as the techniques mini manual and a sample rib chapter from the Advanced Myofascial Techniques book. And there at that URL at the top of the screen, advanced-trainings.com/WMC16R, you'll find links to more videos, to the World Massage Conference, the certificate, the continuing education, to lots of discounts, including on the conference itself, on our books, to our sponsors, Primal Pictures, Earthlight, Body Cushion, last but not least, our free e-letter. Please stay in touch, and if you have questions, again, the way to get in touch with us is by our email address or phone number there on the screen, or especially to discuss the techniques, our private Facebook group. So just go to facebook.com/groups/at.distance.learners. AT is capitalized, the rest is lowercase. It's all on your screen there. Check us out. Request entrance to the private group, and we'll invite you in, and there's a great place for discussion and going further into it. Thanks for the World Massage Conference, and thanks for your attention today.